The luxator should be held in your dominant hand, with the handle sitting in your palm held also by your fingers and thumb. You may choose to place your index finger on the handle of the instrument. Alternatively, you can extend it towards the tip of the instrument. Choose the option which allows you to have more precise control of the tip. An operator with less experience may want to hold the luxator with the finger extended towards the tip down the shank. The luxator sizes available to you are 3mm or 5mm, and they should be chosen to match the diameter of the root. The angle of the blade may be straight or curved, and your choice should depend on whichever gives you better access. For example, a posterior tooth with curved roots indicates a curved luxator. The tip of the instrument is inserted into the gingival margin, the blade angled along the long axis of the root surface. Once in the periodontal ligament, the luxator is worked down the length of the root with a rotation motion and apical pressure. This cuts the periodontal fibers from the tooth and expands the socket. As the blade is advanced further down, the socket is dilated by an ingress of air. The luxator should be inserted around as much of the circumference of the root surface as possible to expand the socket. After adequate luxation, forceps can be applied to deliver the tooth. As with all surgical instruments, control is essential to ensure a safe procedure with a successful outcome. The risk of slipping should be prevented by correct handling of the instrument and by using the supportive hand to stabilize and protect the patient's soft tissues. Avoid luxating upper teeth palatally, as this risks damage to the palate. Equally, damage to the lingual nerve can be prevented by avoiding their use lingually. Luxators should be widely adopted for use prior to forceps. They allow for the removal of the tooth with less force and therefore preserve as much alveolar bone as possible, whilst also providing a better experience for the patient. An advantage which luxators have over elevators is that there is no contact with adjacent teeth, and they are less traumatic and preserve more bone. Thereby, they reduce local swelling, inflammation, and risk of infection. Now you will see a demonstration of luxator use in the mouth. First, the teeth being extracted are anesthetized using local anesthesia. A 3mm straight luxator is inserted between the gingiva and the second upper premolar. The tip is moved vertically down along the root surface of the tooth with a gentle rocking motion. This cuts the periodontal fibers, detaching them from the alveolar bone distally. The same motion is repeated both medially and mid-buccally before the application of forceps. The tooth is delivered with upper premolar forceps using rotational movements. Once extracted, the apices are checked. As the lower premolar is luxated in a similar fashion, note the grip on the instrument. The index finger is placed on the handle rather than on the shank of the luxator to allow for better control. Again, the tooth is luxated medially, mid-buccally and distally before applying forceps. The index finger of the left hand serves to retract the lip, but also protects the patient's soft tissues from damage in case the luxator slips. The middle finger is placed under the mandible for support and stability, as both the luxator and the forceps should be applied with continuous apical pressure.